Welcome, folks. We'll give people another couple minutes to join.
Hi, Kathy. This is Jenny, and I am in the conference room. And if you can hear me, then we are successful. And we've got Molly Slesnick and Amanda Lee in the conference room.
I can hear you. Welcome.
Thank you.
And for folks just joining, we'll give people another minute to get on. Welcome, folks. We'll give people 30 more seconds. Okay, why don't we go ahead and get started with introductions, and then we can catch if there are, I'm sure there'll be folks joining a little bit more, and we'll try to catch them after. For those who don't know me, my name is Kathy Kilring Del Rio. I use she, her pronouns. I'm the Advocacy and Programs Director at Maine Equal Justice and Chair of the MaineCare Advisory Committee. I see a few people who aren't usually here, so just so folks know how introductions go, we normally start with MAC members and alternates. And is somebody trying to say something? We start with MAC members and alternates, and then try and ask that folks share their names, pronouns, organization if that's appropriate for them. And then we hear from folks at the Office of MaineCare Services, and then we hear from guests. So I will go through using the list that I have of our updated MAC list. Piper Stiles.
Hi, can you hear me okay?
Yes.
My name is Piper Stiles. I use she, her pronouns. I am a full-time student at UMA in the Justice Studies program and also the Trauma-Informed Emergency Management program. And my daughter and I have been MaineCare recipients for about the last 11 years. And I am a recipient member of the MAC.
Thanks, Piper. Esther Miller.
Morning, everyone. Esther Miller, MaineCare Program Manager with the Office for Family Independence. OFI manages eligibility for MaineCare, and this will be my last MAC meeting with you all. I am transitioning to ODES, the Office of Aging and Disability Services, later this month.
Oh, wow, that's a big change, Esther. Congratulations. We'll miss you. Jamie Cotnoir.
Good morning, I'm Jamie Cotnoir. I'm the Associate Director for the Division of Disease Prevention at Maine CDC.
Mallory Shaughnessy. I don't think she's here today. Kathy Dion.
Good morning, everyone. I am Kathy Dion, the Executive Director for the Autism Society of Maine. She, her, hers.
Becca Matasovich. Vicky McCarty.
Good morning, I'm Vicky McCarty and I'm with the Consumer Counsel System of Maine, which is an organization that's made up of folks who have lived experience with mental health issues, and we do public policy work and advocacy. Thank you.
Rachel Collmore.
Good morning, everybody. Rachel Collmore. I'm the Consumer Assistance Program Manager at Consumers for Affordable Healthcare.
Sarah Squires.
Good morning, Sarah Squires, she, her pronouns. I'm the Public Policy Director at Disability Rights, Disability Rights Maine, and we provide legally based advocacy services for individuals with disabilities throughout Maine.
Gia Drew.
Good morning, Gia Drew, she, her pronouns, Executive Director at Equality Maine.
Thank you. Sorry, I was trying to toggle between windows and lost my place. Susan White.
Good morning, I'm Susan White, she, her pronouns, and I am representing the Home Care and Hospice Alliance of Maine.
Catherine Hamilton. Leo Delicata.
Leo Delicata, he, him pronouns. I am an attorney with legal services for the elderly.
Sarah Lewis. Laura Cordes.
Hi, good morning. Laura Cordes. I use she, her pronouns. I'm the Executive Director with the Maine Association for Community Service Providers, MAXPE.
Rachel Dyer.
Hi, I'm Rachel Dyer, she, her pronouns, and I work for the Maine Developmental Disabilities Council.
David Winslow.
Good morning, David Winslow with Maine Hospital Association.
Oops. Dan Morin. Beth Pierce.
Hey, I'm Beth Pierce, the Oral Health Program Manager with the Maine Primary Care Association.
Candy Henderly. Teresa Cochran. And I think Kaylee Hess is here for Becca Matasovich.
Hi there. Yes, this is Kaylee Hess, Children's Oral Health Network of Maine. I use she, her pronouns.
And did I see Sarah Lewis and the folks from Maine join?
Yes, thank you, Kathy. It's Sarah Lewis, she, her pronouns. I'm with Maine Access Immigrant Network, and I just couldn't rename my nameplate on the thing. Sorry.
No problem. Thank you. And are there any other MAC members or alternates who I missed?
Good morning. I'm Suzanne Farley. I'm an alternate with the Maine Association of Mental Health and Substance Use Treatment Providers. And I'm also the Executive Director for Wellspring.
Thank you. Okay, I'll pass it over to OMS. I see Michelle.
Good morning, everyone. Michelle Probert. I use she, her pronouns, and I'm the Director for MaineCare. I'll pass it to Jenny.
Good morning, everyone. I am Jenny Patterson. I use she, her pronouns. I am the Director of Policy for the Office of MaineCare Services, and you will see I appear twice on the screen. That's because I'm in the conference room at our office. So let me pass it to the folks who are in the conference room to introduce themselves, and then we have a number of other team members who are joining just on Zoom. So Molly.
Hi, good morning. Molly Slotsman, Chief Operating Officer for MaineCare, and I'll pass to Tia.
Hi, good morning, everyone. Tia Baldick. I am the EPSDP Coordinator at MaineCare. Hi, I'm Amanda Lee, the Rate Setting Coordinator for MaineCare, and I use she, her pronouns.
Great, thank you. And I hope folks can hear us. If not, please let us know. Sometimes we have to speak up quite a bit when we're in the conference room. So if you're unable to hear, please let us know. And I will pass it on to some other MaineCare folks who are on, Sarah Fisher.
Morning, everyone. I'm Sarah Fisher. I use she, her pronouns, and I'm the Children's Health Insurance Program Outreach Coordinator for MaineCare. I see Melanie Miller.
Good morning, I'm Melanie Miller, and I'm with the Children's and Behavioral Health Services Policy Unit. I'm a policy writer. I'm not sure. I'll pass it back to you, Jenny. I'm not really sure who else is with us from MaineCare.
This is Lisa. I'm with MaineCare Policy, Lisa Weaver, and she, her, hers. And I believe we have Shannon Martin on as well.
Thanks, Lisa. Shannon Martin. I am part of the communications team for MaineCare.
I think that's everyone. Yeah, go ahead.
Oh, no, that's great. And I was going to say, for those of you in the conference room, I think we can hear you, but I do think when you're speaking up, it's a little easier. And just circling back, are there any other MAC members or alternates who were missed?
Morning, Kathy. Mark Eves, alternate for Max B. Executive Director, Woodford's Family Services. Pronouns he, him. Good morning.
Thanks. All right, anyone who's a guest, you can either enter your information in the chat or take yourself off mute.
Ben Townsend, attorney at Kozak and Geyer, and I use he and him pronouns.
I think a few people are sending their messages, but they're coming directly to me and not maybe going to everyone. At least that's what it looks like in my chat. So just if you're sending a message that you mean to have everyone see, just make sure it's being set for everyone.
I think I just fixed that. For some reason, this particular Zoom account has this weird thing where it shuts off the chat, even though it doesn't say it's shut off. And so you have to like click twice to fix it, which I just did.
All right. So those of you who
Sorry,
sent me
everyone.
a message, maybe now it'll work. If not, I'll try to share. Oh, great. Good. It's fixed. Yay. Thank you, Michelle. Okay, so let's go ahead and jump into our agenda, and I'll pass it back over to you, Michelle, for updates for MaineCare.
Great, thanks. So I don't have too many updates today that are not otherwise covered in the agenda or that have not already gone out via e-message. And I'll always take this opportunity to remind folks that if you're not signed up for our e-message listservs, please do so, because there's a wealth of information that is shared through that vehicle. I will say, and I forget what the specific status was when we met a month ago, but two very significant things. One is that the CAA, which stands for Continuing Appropriations Act, I think, passed right around the new year. And in that act, they decoupled the continuous coverage requirements, which are the requirements that have meant that people enrolled in MaineCare, thank you, Esther, Consolidated Appropriations Act. I always get that wrong. So the continuous coverage requirements are what have kept individuals enrolled in Medicaid enrolled throughout the public health emergency with few exceptions. So with the Consolidated Appropriations Act, they decoupled that requirement from the public health emergency. So previously, it had been tied together. The CAA split those apart and said that while states have some flexibility for starting earlier, by April 1st this spring, all states have to have started the process of going through redeterminations for everyone who is enrolled in Medicaid to determine whether or not they are still eligible. And Maine is starting that process on that April 1 date. So that is one big topic, and we'll talk a little bit more about that later on the agenda. And then separately, President Biden announced that the public health emergency will be ending on May 11th. So he broke the streak of 90-day renewals that we have all come to rely on. So May 11th is the day the public health emergency will end. And for those who have not been tracking, the public health emergency is still tied to the flexibilities we've had from a policy perspective, so that we've been able to do things with disaster state plan amendments, which has enabled us to do things more quickly than usual, not having to do the regular noticing that we do, and also having flexibility to go retroactively. The things that we have done under DSPA in order for those to continue past the public health emergency, where appropriate, we need to seek regular state plan amendment authority, and also in cases conduct rulemaking. Aside from DSPAs, for home and community-based service waivers, the vehicle was called an Appendix K, and similar to the DSPA in that it provides more flexibility than usual. The biggest difference between the Appendix K for HCBS waivers and the DSPA is the Appendix K is actually the flexibilities go until 6 months after the end of the public health emergency. So that will be November 11th of 2023. So there is also the coverage for uninsured individuals who aren't otherwise eligible for MaineCare, for COVID testing and treatment and vaccination. That coverage group also goes away at the end of the PHE. If folks are interested, we can certainly at a future MAC have a more in-depth presentation about implications of the end of the PHE. So those are the two big things that have happened since last time around. And I think Molly had a quick update as well.
Just gonna do my recurring monthly reminder about the requirements for attending provider NPIs on institutional claims. The deadline for this requirement is April 1. We did push the deadline out in order to align with MaineCare enforcing the requirement. So I will look for an e-message about that and put it in the chat, but I just wanted to put in my monthly plug. We have made a lot of progress on providers complying with this requirement since I'd say the end of the summer. Really a lot of progress. So thank you all for that. But there is still a little bit of ways to go to have providers appropriately attending provider NPIs on their institutional claims. So thank you in advance for your support getting the word out and helping providers be compliant with that. And any questions, you can reach out to your provider relations specialist.
Kathy, I'll grab that question from the chat from Alexandra. COVID testing and treatment coverage ends on May 11th. It does not have the same adverse requirements that regular coverage has, and it does not have appeal rights. People who are losing coverage in this group can apply for full MaineCare. They can do that by visiting My Maine Connection, creating an account and applying online. They can go to the OFI website and download and print a paper application. They can call. We'll be accepting telephonic signatures. That's ongoing. So if someone is calling, maybe they have SNAP and maybe they'll have to complete an interview, or maybe they also have TANF and the same. Maybe they need to speak with someone at OFI. They can apply for MaineCare over the phone.
And again, just for clarity, and thank you, Esther, for that response, that's just for the uninsured group that got access during the public health emergency to COVID testing and treatment. It doesn't mean that all coverage for COVID testing and treatment ends. I think it was shorthand in the question.
Great. Should we move then to MaineCare bills from the department that should be flagged for MAC members? Is that you, Jenny?
Yep, that's me. Thank you. And Kathy, you had asked, excuse me, for an update on MaineCare requested bills. So there are 3 bills that have been published so far that were requests of MaineCare. And after I summarize them, I can put in the chat the bill numbers. First one is LD 84, an act to strengthen third-party liability requirements for the MaineCare program. And this is a bill that we submitted in order to comply with federal regulations. It adds third-party liability requirement provisions for MaineCare claims for payment. And then it also adds a provision that applies MaineCare assignment provisions to out-of-state carriers who provide coverage to residents of this state. And it results from a appropriations bill that the president signed in March of 2022 that did require states to adopt these provisions. So again, LD 84, that's the number for that one. Then the next one is LD 282. This is an act to allow the Department of Health and Human Services to authorize standing orders. And basically the purpose of the bill is to improve member access to vaccines and non-prescription drugs. It's needed because federal Medicaid regulations require that authorized licensed health providers must prescribe, even if it's an over-the-counter drug or a vaccine. And so this bill would allow GHHS to authorize standing orders for these vaccines and non-prescription drugs to be dispensed to MaineCare members, and also to participants in the state-funded medical program for non-citizens, enrollees in the elderly low-cost drug program, certain qualified residents, and persons receiving health care. So again, that is LD 282. And then the last one is LD 432, an act to clarify MaineCare program requirements regarding certain high-risk healthcare providers. This is also a bill that the department submitted to comply with federal requirements, and it clarifies the MaineCare program requirements regarding certain high-risk providers. And it requires a person with a certain level of ownership interest in a high-risk provider to submit to a fingerprint-based criminal history background check. I think we previously included these provisions in the rule, but the FBI requires it to be adopted in statute. So again, that is LD 432. And I believe as of yesterday, those are the only ones that are published at this point.
Jenny, I know that MaineCare in the past has said that you don't want to share language from bills that aren't yet printed because you want it to be public for everyone at the same time. Is it possible to flag which bills are currently bill titles so people like have their eyes open for those when they get printed?
Kathy, I think we can ask Molly Bogart that question. So we'll ask her and circle back.
Great, thank you. Great. Before we move on to our next topic, I did also just want to name 2 logistical things. One, my household got hit with some illnesses after our last meeting, and then session started. So those of you who volunteered to meet to talk about MAC goal setting plan, I am going to reach out to you this week. I'm finally caught back up. So my apologies for that. And I'm not sure if the provider group came together yet, but I think many of you know that Mallory's mother passed away recently. So she was the one who was going to pull that group together. So bear with us, and we'll make sure that happens soon.
Hey, Kathy, the provider group is planning to meet tomorrow.
Oh, great. Oh, well, she was on top of it without that. That's great. Thanks, David. Okay, great. So next up is the unwinding of continuous enrollment. And I'm not sure who should take the first piece, but there was a couple questions about whether there will be a stakeholder meeting. Again, we talked at the last meeting that there likely would be.
Yep, I can start. So you get the late breaking news that's not out there officially yet, but we yesterday found a time. It is soon, but we are sacrificing notice for urgency of information. So a week from Thursday on February 16th from 9 to 11, we are working on getting an invitation out there. So it's not out there yet, but if you are interested, please hold your calendars. It's actually, it might end up being 9:30 to 11, but that is the general time that we are looking at. And similar to the last time we did this, which was long ago, last September, this will be a cross-departmental presentation. So Office for Family Independence, MaineCare, as well as Office of Health Insurance Marketplace will all be participating in that forum. So that is the update there. And I'll just flag that on the next topic, we won't go there yet, but on new coverage categories, Sarah Fisher, who's here with us today from MaineCare, has a bit of an update on communications related work for unwinding, as well as for those new coverage categories. So she'll talk a little bit more about that under the next agenda item. And I think we can go to Esther with some of the more specific questions right now.
So I'll start by addressing items that are actually listed on the agenda. People who have MSP, I think I needed a little bit of clarity about what this question was asking. So people who have MSP and are duly enrolled are individuals who have Medicare and Medicaid, and thus they qualify for MSP as well to help with those premiums and cost sharing requirements. For those who are determined no longer eligible for MaineCare, MaineCare eligibility is not the criteria for MSP eligibility. It's Medicare that's the requirement for MSP, and then meeting the MSP eligibility guidelines. So meeting the MSP FPL, income asset, those pieces. So a loss of MaineCare coverage does not necessarily equate to a loss in MSP coverage. Certainly when we're closing anyone off of any level of coverage, we're determining whether they fall anywhere else in the hierarchy. So again, we have a long list of all the different coverage groups that we have. In OFI, we call them program type codes. They're very specific. And when we're determining eligibility, we run an individual through that hierarchy, through that list to see where they fall. With things like pregnancy related coverage or SSI related coverage, someone who's open SSI and therefore guaranteed Medicaid coverage, those items are very high. And then limited benefit, like the limited family planning benefit, special benefit waiver, those items fall lower on the hierarchy. MSP coverage. And with MSP coverage, if someone has Quimby, but their circumstances have changed, their income has increased, something like that, then we would test them for other levels of MSP coverage. So SLIMB QI coverage. It's like a little mini version of what happens in Medicaid. So just to be clear, loss of MaineCare coverage does not mean loss in MSP coverage. As long as someone has Medicare and qualifies for MSP, they will keep their MSP coverage. And
Esther, do you mind if I say something else about MSP?
Yep, let me just finish because there's a couple other points and we have some late breaking MSP news that I need to share. For those eligible members who may have a shift, OFI does not refer directly to the AAAs. We have 211, the notice of decision certainly lists some options for other levels of coverage or other places to go. Those who are losing coverage because not just MSP, but MaineCare coverage because they are deemed over income, we're referring to the marketplace. So the eligibility specialists individually are not making that connection, but there are resources out there to connect people with those AAA agencies. And then late breaking news about MSP that just came through throughout the PHE. Medicare has been considered tier 1 health insurance. So people who have been open MaineCare and then at some point during the PHE become eligible for and begin receiving Medicare, we've been able to disenroll them from MaineCare and give them MSP coverage. There's been a federal court case, and I don't know all the details about who brought the case or what the actual case is called, or even what court it's in. But Leah just told me that the case is at a point now where we will no longer be ending MaineCare coverage for those individuals. MaineCare will continue, MSP coverage will continue. This is a very new development, so our staff is not aware yet. We'll be correcting that first thing tomorrow morning. And certainly the population is not aware of that yet. We don't have any guidance from CMS specifically. So what you are likely wondering is what sort of backdating might we be doing? And we don't have an answer for that right now. So at this point, for this month, prospectively, MaineCare coverage will be maintained. Once we get clarifying information from CMS about what to do for previous months, we'll certainly address that piece. So that's all I have for MSP.
Thanks, Esther. I'll just chime in because that was the same thing I was going to say. Just so you have a sense of the late breakingness of the news. Yesterday, the director or the administrator for the Center for Medicaid and CHIP Services sent out a letter to all state Medicaid directors informing them of this news. And I think today CMS is holding a call with states for further guidance. And so very much emerging in terms of what this specifically means for states. And just a slight correction, Esther, I think that it was actually in November of 2020, so not right at the outset of the pandemic, but in November when CMS had issued the guidance saying that if someone qualified for MSP, then they could be transferred to that coverage. I'm probably using the wrong words, then you could do so. It was at November 2020 when that started happening, and the lawsuit was regarding that transition. And I put the name of the lawsuit for folks who like to look up cases in the chat.
Great, thank you. Next on, first, are there any questions about MSP?
Well, and I'll just say, Esther, because a couple of people were asking me questions. As you said, it's the Medicare savings program. So basically MSP helps people who have Medicare with the costs, the out-of-pocket costs associated with Medicare. So, and there's different tiers of that program, which is what Esther was referring to with QIMBY or SlimB or QI.
Yes, there is an entire part of the MaineCare eligibility manual dedicated to MSP coverage and details about each of those tiers. Are there any other questions about MSP? Okay, next up for me, oh, look, we're running a little ahead. That's great. Next up for me, we're looking for enrollment numbers. So federally non-qualified individuals, we still don't have enrollment counts on. The data team at OFI is aware that we are looking for that information. As you can imagine, they have been extraordinarily busy getting ready for the beginning of the unwinding period. There's an immense amount of technology work that we've been going through at OFI in order to make this transition. So they're a small team and they will certainly provide that data as soon as they're able to for The unborn child option, I got a report yesterday. We get that report weekly and we were at 47. I think that Sarah Fisher may be speaking a little bit more to what we might be able to do to assist with increasing enrollment in that group. You're never going to see a large number in that group, I think, not only because it represents a very small part of the population, but because of the nature of the coverage itself. It's coverage that's available to a pregnant woman who does not have a qualified citizen status during her pregnancy. So where the pregnant postpartum period is considerably long, so you're going to continue to see an increase in enrollment and then kind of a leveling off. The unborn child option, I think you're going to see a little bit more frequent turnover in who those members are from month to month. And that's all I have for agenda items. I do want to say that the stakeholder meeting for the entire unwinding process is going to be fantastic. There's a lot of really, really great information. So once those invites go out, I would really encourage you all to join that call if you're able to. There's a lot of layers involved in making sure that folks have access to health insurance, and we're doing everything that we can to make sure that you all have that information at your fingertips. So certainly make that a priority if you're able. Does anyone have any other questions about eligibility for me?
Esther, there's a question, just a clarifying question. It's 47 people for a month. Is that what
Nope.
you're
So
saying?
anytime we get a population count, it's a moment in time.
Okay.
So I get that report weekly. It tells me each week how many individuals are enrolled in that coverage group. So, you know, for a 9-month period, I may see the same individual on week to week to week, but then when the pregnancy ends, that individual is not going to continue to be on the report. So yesterday we had a count of 47. That's a little bit lower than what it has been. It's been pretty consistently 60 to 65. I wouldn't be surprised to see it come back up to 60 or 65 over the next couple of months as new pregnancies occur. But again, it's been a pretty consistent volume.
Thanks. And I'm not sure if this is a question for you, Esther, or maybe it's a Michelle question. So for the folks who are under 21, the department must have a sense of how many people are in that category in order to budget for that in the biennial budget, right? Or is that not?
So
maybe I don't understand how the budget works.
The fiscal process for creating a new coverage group is extremely detailed and complex. It's a different set of information than the real live data once you go live with a program. So the ongoing question is, how many people are enrolled? That's different than our projection of how many people might be impacted by the coverage. So as soon as our data team is able to build the report in order to identify that population as they're actively enrolled, we'll be able to share that information. They just haven't been able to prioritize that work because they're a very small team and they have an intense workload right now getting through unwinding data requirements. So as soon as we have that volume, we'll be happy to share it. I just don't have it at my fingertips right now.
Okay, thank you. Any other questions?
I can share just so people have an idea of scope separately, as there's lots of fiscals bumping around. I had asked a question about number of kids who are covered with the state only covered option right now, and it's in the 700 to 800 range. So that is not precise. And I'll give a qualifier that that is not a number that the OFI team has officially generated, but that is coming from our analytics group. So it should be relatively accurate.
And I'm sorry, did you say 1700?
No, I said between 700 and 800.
Oh, okay. That makes more sense to me. Okay. Thank you. And I see it, yeah, and there's a question about the unborn child option and like, where does that language come from? And it comes from a CHIP option that was created at the federal level during the Bush administration, thus the language around unborn child as opposed to the scientifically accurate term fetus.
Yes, one instance where I like to just say the acronym instead of spelling it out, because I can imagine the conversations that happened to land on that name of that specific coverage.
Yeah. Okay, thank you. And then I think now we're ready for Sarah.
Yes. Hi, everyone. Hopefully in some of this outreach work, we can not use that official language when we talk about these coverage options to people. We're able to tweak it and make it much more approachable and inclusive. I'm Sarah Fisher. I'm doing a lot of outreach work for MaineCare in regards to these two new coverage groups, as well as just general children's programs outreach. For those who don't know, we've been working with Ethos, which is an external marketing firm based out of the Portland area. And they've been helping us do a lot of resource development and branding and really tweaking messaging for a lot of these programs as we look to outreach to families and folks throughout the state of Maine. So I can give kind of just a really high level overview of some of the different projects we've been working on. At any point in time, please feel free to ask any questions and I'll keep an eye on the chat. For PHE work, they developed a toolkit for us that includes a poster, a flyer, a wallet-sized card, and digital assets, including Facebook and Instagram and banner ads. Those have been completed with OFI's approval. They're awaiting OMS's approval, and then they will be ready to go. They've also been working on a microsite for us, kind of a landing page that folks can go to that, if folks are interested in applying for MaineCare. It gives a lot of information about what MaineCare is and directs people to My Maine Connection. And it's also a good landing page for people who already have MaineCare coverage and have questions about what services they are eligible for, or what services can they receive while on coverage, and just kind of answer some general questions around MaineCare coverage. And so we're hoping that that site will be a bit more approachable for folks, will be in more plain language, less kind of government-y than kind of our DHHS site, so that folks can access that. Ethos has prepared kind of they call it the copy, which is really just kind of in a Word document, like the actual like language written out. And then once that gets approved, we sent feedback to them yesterday on that. They will actually design the site and we can work on getting that approved and kind of online. They also are developing 2 30-second radio spots about the ending of the public health emergency and the unwinding, really emphasizing if it's blue, it's time to renew, giving folks information on what they need to do to keep their MaineCare coverage. We have a meeting with them on Thursday to kind of, I think, go over the proposed language around what the radio spots will say, with the hope that those will be kind of ready to go and be live by mid-March, so within the next month or so. For the new coverage group kind of outreach work, they also have been working on a toolkit for that, including a poster, a rock card, and Facebook and Instagram sponsored posts and ads. Those have been approved by OFI, awaiting OMS approval. Those will be ready to go pretty soon. They also are working on some transit ads, bus ads in the Portland, Lewiston, Augusta, and Bangor area, I think, are the 4 kind of cities that we're focused on. And just putting an ad in some of the bus systems around to try to reach folks there, as well as a newspaper ad in Anjambo, Africa, which is a newspaper, kind of a digital print newspaper out of the Portland area that really a lot of new Mainers use as well. So using those 2 kind of mediums to try to outreach folks. And the big thing with that will be the translations, making sure that the materials that we create are translated in the languages needed to reach the new Mainers, the most common languages, so that it's accessible. And then just a quick update, I guess, on just general MaineCare children's outreach. They've also worked on a toolkit as well that's finalized. We've worked with Maine Parent Federation and Developmental Disabilities Council on getting a kind of Katie Beckett booklet, like application kind of process booklet, printed and designed, so that is available on Maine Parent Federation's website. We're also working on a video for the Katie Beckett application process, as that is a bit more burdensome process and confusing process for families really wanting to make that as accessible as possible. We've been working with CAKE with Rachel Collymore, who's on the call, for a documentary series looking to interview and work with families across Maine who have MaineCare, and just be able to tell their stories, and make, I think the ultimate goal for that project is to destigmatize MaineCare and make MaineCare as, as accessible as possible for people. They also will be doing some digital social media assets work for us as well, but that's a bit further down the pipeline. I think I ran through a lot of things very quickly. I see some things have popped up in the chat. Let me, will the PHE materials also be translated? Esther, you might be able to answer that. You've been more involved with that project than me. I think so, but can you confirm that? You look like you're thinking about that answer as well.
Sorry, I was multitasking. PHE materials that are posted on our website, I believe there may be a larger, higher level department project to improve translation services, but OFI is not individually providing materials in 15 top non-English speaking languages. We understand that that's not necessarily the answer that you all would like to hear, and it's possible that there may be some options in a few select languages, but that's really all the information I have to share about that right now.
Thanks, Esther. Any more questions that I can answer? And I can put my email in the chat as well if anyone has any. I think we're really open to hearing external organizations' perspectives on some of the outreach work, because you guys are oftentimes the folks who work directly with members. And so if there's any interest in feedback or partnership or anything, please feel free to reach out. I would love to hear perspectives and thoughts from other folks.
Thank you. Oops, hold on a second. Okay. So up next is the rounding rule implementation. So this, I am not an expert on the rounding rule, but we have had many conversations about this here at the MAC. It's been an ongoing conversation. So a few different folks asked for this to be put on the agenda. And Laura, I see your hand.
I apologize, Kathy. I had a quick question before we headed into rounding rule. I think it's probably for Michelle, which is, as you consider all that's there with the unwinding, would you be hosting a unwinding meeting for Appendix K provisions?
Yeah, and the federal government has made it more complicated to talk about these things with recent changes, but so at least in my head now, when I'm talking about unwinding, I'm thinking about the continuous coverage requirements and the April 1st date. That is our first priority as a department at the moment in terms of getting out more information and plans around that. But fully acknowledge that there's also work to be done and conversations that we need to have with the ending of the public health emergency and what that means in terms of flexibilities, both under disaster spa and Appendix K and others. So at the moment within the department, we are making sure, because it's not just MaineCare either, there are other implications for TANF and for DLC. And so we are making sure that we have a good handle on what all those different items are and getting on the same page internally. And then we'll be having discussions about how to engage more broadly, which we know we have to do, but I don't have concrete plans for you at this point. But yes, we will be having conversations with stakeholders on that.
Sounds like maybe after April is what I could share with the larger provider community.
I mean, we haven't discussed a date yet. I mean, after April is going to be pretty close to May, so that seems a little bit late. I mean, for Appendix K, I think we have like more, we've got more time then since it's an extra 6 months. So we might need to utilize that flexibility to prioritize some of the disaster spa flexibilities, et cetera, that will end in May. So more to come because it's all happening at once. And
right. I can really appreciate that. And thank you for your response. I know I've already gotten a lot of questions about it. And I said, I'm sure there will be a plan, but everything in its time. But thank you, Michelle.
So back to the rounding rule. So it says this in the agenda, but just in case there's anybody who's not looking at the agenda, 2 particular things were flagged in advance of the meeting. One, providers expressing concern about the implementation timeline and the costs associated with technology changes to implement those changes. And then also a conflict between the new rule and EIS for Section 13 adult case management providers. So Jenny, are you taking both those questions?
I can, Michelle, unless you want to. I think I already posted in the chat the FAQs that we issued in early January, and I think they do speak to the specific question that was asked. I did not post, and maybe Michelle, you can find the link while I'm talking, but we also did post a message about kind of flexibility and implementation. And I didn't post that one. So I might leave that for Michelle. I don't know if you want to mention it first, and then I could do the more specific question.
Yeah, I can lead with that first, Jenny. And if folks didn't hear Jenny, we will post a link in the chat. We put out an e-message to indicate that we will be exercising enforcement discretion on the rounding rule, which went into effect on January 1, but we will be employing enforcement discretion through to April 1 in acknowledgement of systems difficulties that folks are having. So I think we'll share that link, and that is the broader flexibility that we're allowing. And Jenny, if you want to talk to the targeted case management and EIS question, or Mallory, if you had a broader comment you wanted to make before we dive into that, go ahead.
Thank you. So I was actually getting ready to send you an invitation to see if you could join the newly formed provider subcommittee of the MAC tomorrow afternoon at 5 for a meeting on this very issue. I'm not sure if you'll be able to make that or not, but we'd love to have you. We're looking into some issues with non-compliance with HIPAA due to this that we need to run by you and discuss. We're also looking to get somebody from the AG's office just to help clarify. So we'd love to have you join us if you could at 5 tomorrow. It's sort of an emergency meeting to discuss this with some information that's come up.
We'll have to look into availability. That's short turnaround for us. And I can say that especially if there's a legal argument, we would not be able to respond real time. We would need like written information to be able to share and review. So I'm not sure even
it would be giving you some information. Yeah, it would more be just giving you some information to take back and take a look at if you can join us. If not, I can send it to you via just email, but it'd be great to just be able to chat a bit about it, even though I know you wouldn't be able to respond in real time with any answers.
Yeah, and we did actually receive some feedback that was related to HIPAA, although unlike anything else that I've ever heard about with HIPAA, it wasn't particularly privacy related. So we have looked at that a little bit, but we can huddle internally and let you know whether someone can be available for that conversation.
Okay, great. Thank you very much.
Mark?
Great. Thanks, Kathy. My question is a little bit more specific, but did want to first acknowledge the thank you to the extension to April 1, huge help in implementing this. So the specific challenge that we're having and needing some guidance on related to section 13, particularly IDD adults case management, is the requirement to document in the state's EIS system. So we're changing our electronic health record to allow for partial units, but the EIS system only does whole units. So there's a discrepancy between what's in EIS and what we're going to be billing for. So I imagine, I know there's a lot of work of transitioning a system away from EIS to the new one. So I imagine there's not going to be an opportunity to do partial billing in EIS. And if that's the case, just guidance on, do we round up? Do we round down? Do we put a narrative note? The exact time that we're billing for? Will program integrity be looking, what will they be looking at in an audit to justify the service? Does that make sense?
Yes, and Mark, I think that we did provide an answer in the FAQs, and I don't know whether you looked at this answer, but basically one of the key concepts in the rounding rule is it applies to all sections of policy unless there is specific language in that section of policy to the contrary. And with respect to section 13 in particular, there is specific language that states that providers of services reimbursed on a quarter-hour basis under this section will be reimbursed for any substantive contact at a minimum of 15 minutes. And so section 13 providers should continue to bill in accordance with this provision. And I think that reduces the tension around the EIS provision. So in other words, there is provision to bill for a full unit, and that's what EIS would provide. But that is one of the FAQs that's in the link that I posted.
Okay, I'll take another look at that. We did read it, but there was some additional questions around. So we just continue to use the system essentially the way that we have been using it around
For section 13 specifically, it would be a full unit.
Okay, so do we use we use the 80% new 80% rule, not the 50% or
Again, because there is specific language in section 13 that says any substantive contact gets billed as a 15-minute unit. And again, we can talk more if that doesn't answer all of the questions, but I think that's key is less of a change for that section because there is specific language.
Okay, maybe we can talk offline. I thought it was just the first unit that's anything subsequent, and then anything after that would apply to the 80% rounding rule. So often we'll meet for an hour, or we'll meet for, let's say, 48 minutes. We do ask our case managers to be very accurate in that. So I just want to make sure that we can partially bill.
And Mark, my understanding, which may be tenuous, aligns with what you just said, that that's really about the first unit. The FAQs do speak to that. I will also say that MaineCare specifically had conversations with ODES about the EIS system prior to going live on this, and there are a couple of questions in that regard in the FAQ as well. And the agreement between OMS and ODES at the time was that there did not need to be EIS system changes, and that there was a field where there was the request to document if you needed a partial unit. I asked our teams to connect on that to make sure that that was still the mutual understanding, because questions have come up. And so it might be a matter of just getting more specific about like what it is that needs to happen in EIS, and whether or not that, I don't know if there's any systems issues from the provider side in terms of that, but the initial conversations between ODES and OMS was that EIS would be able to handle the change.
Okay, and I think it is a narrative, kind of putting in the narrative box the actual minutes that we are with a client. So yeah, I think a little bit more follow-up and clarifying for that. I mean, it's a matter of rounding up or down on the units that we put in EIS, and we're putting to the exact minute in our billing system. So that's how we're programming it.
So maybe as a next
to download and upload and export, and if we use EIS, we're gonna be losing a lot of partial billing.
And I remember that the FAQ does say that EIS will reimburse to the precise minute. So I think as a next step, if you could look back at those FAQs, and then it would be helpful for us to have in writing like what specific follow-up questions, or if there's any confusion, or if there's something that doesn't seem to make sense. If you could document that for us, then we can get the ODES team and the MaineCare team together again to make sure that we're fully answering questions.
Okay, great. I will do that. And who should I send the follow-up to? Who should I include?
Jenny, who should that go to on, or is that, yeah. Should that go to someone on your team, or is that a provider relations issue?
I think I'd like to be included because there's multiple team members just because of the nature of section, chapter 1, section 1. So I can put my email in the chat.
Okay, awesome. Thank you all. I don't want to take more time. This is helpful. Thank you.
Yeah, in the spirit of time too, Kathy, I mean, I don't even know what EIS is, but I can just tell you that there are a lot of similar type of documentation issues that we're dealing with at the hospital level, at the physician practice level, and it all really does revolve around, you know, the standard billing practices under federal law are pretty specifically laid out, and we're going away from that here, and it's just creating a cascade of issues in any attempt to do that, because all of the medical records and all of the documentation systems that we use are all standard nationally. And so there aren't any provisions for this. This isn't like an option that you can choose. It has to be totally created. In addition to the fact that all of the professional offices are going to have to change, you know, the way that they document this as well. And as Mark said, it's not as though the clinicians don't keep track of how many minutes they spend with the patients, because they do. It's just that it's tracked and recorded in a much different fashion under federal HIPAA law than it would be required under here. And I think that's sort of the crux of the issue. And you know, we are meeting tomorrow, as I said, with Mallory and others, and every intention, Michelle, would be to submit all of this in writing for your consideration. Like, as Mallory said, there's no you know, it's just one of the things we found, I think, is that, you know, we're not experts in this area, but there are people who are, and, you know, it takes a while for that to process through the system. And so I think, you know, a consideration of something in writing is certainly what I had in mind. And I think others as well, that I've spoken to a number of them. So.
Mallory?
David just really kind of spoke to what I was going to speak to. But yeah, it's the operationalizing this has become just a a real problem. There are some providers that have got it into their systems, but it doesn't flow well with any of the process of work and documentation. So yeah, we definitely have issues that we need to discuss further.
I'll share that. I mean, a lesson learned for me and for MaineCare through this process is that while I know that we discussed this at least at a couple MAC meetings prior to January 1, and we had been requesting that providers share concerns with provider relations, so we had an accurate sense of the issue. And like for the concerns we were hearing, we were finding that we were able to, at that time, address them, or there was some confusion. So the lesson learned is that we should have communicated more than that and issued more reminders. But it's challenging because this rule was adopted last May, and based on feedback, we delayed implementation until January. But it would have been more helpful if we'd gotten this flood of comments and specifics prior to adoption of the rule versus once it was adopted, right? So I know that's easier said than done, but the APA process is out there for a reason. And like I said, we should have communicated more once it was adopted to make sure that everybody was aware of what was coming, but we're in kind of a tough spot now.
Yeah, I would just say, speaking for myself, I agree with you, Michelle. I mean, we should have been paying a lot closer attention to some of these details. I agree with you 100%. We didn't respond the way that we should have. I mean, there were mentions of it, obviously, in the comments that were made, you know, as in the lead up to that rule. But in reviewing them, you know, they weren't as specific as they needed to be. And I just think, you know, until people tried to implement it, I think, unfortunately, for better or for worse, some of those things didn't really come to light in a way that they're coming to light, you know, at the moment. And I think, you know, I wouldn't really sort of pin it on the communications from your end as much as that is just it's a tough issue, and it's something that a lot of people, again, speaking for the people I represent, you know, didn't understand and still don't understand, to be honest with you. I think in talking with a number of people, that the more people understand it, the more, you know, issues seem to be coming up. And that's, like I said, certainly a big part on our end as well. Readily say that, and a conversation we've had quite a number of times around our tables too. So,
Mallory?
Yeah, I would just tag on. I think you did communicate it quite often, and the problem is providers started queuing up to get vendors to come in and do some of this work, and that takes months with, you know, workforce issues they have. And so by the time people started getting into the nuts and bolts of it in the fall, it was becoming apparent that it was going to be very problematic. And that's when we started coming to the MAC saying we really need an extension beyond January, because we're now getting into the weeds of it and realizing the problems with getting it implemented. And so, you know, sort of it's just one of those situations that timing and getting staffing and vending and, you know, all these folks on board to do the work. And then you don't realize, it's like the devil's in the details. As soon as you start getting into it, you realize the complexities and the problems, and then the implementation and getting providers to understand and clinicians to understand. And, you know, it just snowballs into this problem. But the point I want to share too is, a lot of times providers don't always just reach out to their provider relations person because they don't have any answers. And so they reach out to them and they're told, we don't know. And so they don't bother contacting them again to give them more detailed information. And so and we've never really used the provider relations in that way to gather more information, because we end up running into that. So we need to kind of maybe have a discussion around the use of provider relations as the data gathering for showing when there's problems like this. I think that's maybe another kind of a big system conversation that we should have.
Laura?
Thanks. You know, I would, Mallory articulated some of the things I was going to share from our rates subcommittee report, because we had brought to the attention of the department, our ongoing request, because it had been a concern among the provider community, bringing it to the associations and different providers that we'd been discussing, as Mallory articulated, towards the end of the year, both realizing that software vendors were behind, but then the additional challenge of new rates coming right at January 1, then for folks that were getting caught up with software vendors, had to go back and redo that work. So both in November and December, sharing that, more time would be needed. If there's feedback for us about how to bring more examples to you when there's a challenge, but certainly, I'll give that feedback to providers that, yes, please also share it with provider relations specialists, but I certainly assume that, we were bringing something forward from the provider community through our reports. Thank you.
Any last thoughts or questions?
I will just say that I agree. We've started this conversation a little bit, but I think that I think provider relations is an important team, and they're for many reasons, and they are important to MaineCare in terms of escalating issues. And also we often hear through provider relations before we hear through other venues when there are issues percolating. And with the establishment of a provider subcommittee, we've also, I think, talked a little bit both in this meeting and internally that it makes sense for provider relations to play a role there as well. And I, just because you raised this, Laura, as well, when we get to the rate topic, I also want to make sure, and I know that this is sometimes hard, but that we're talking about things in the proper forums. And so the rate subcommittee, tell me if you disagree, but I believe it's intended to focus on Chapter 639 and rate reform and rate determinations. When we get into, and I will not say that this has been a smooth process, but when we get into rate implementation and the operations and mechanics and guidance of that piece, then it's a different conversation. And the folks who are from MaineCare staffing the rate subcommittee, like, it's really about getting to implementation, and internally on our side, we will continue to work towards improving what that transition looks like into go live, but it is not I think that it goes from being like a rate subcommittee topic to a provider subcommittee topic in terms of operations and systems difficulties and everything else, because that's not our rate reform team's specialty or area of focus. And there's a lot on the rate determination side that we need to get through.
I'll just jump in and say I wholeheartedly agree. And now that we are developing that space, I'm glad to move the conversation there. Thank you.
Jenny?
Yep, just was going to add on, I think we're all in agreement, so don't need to go on and on, but I think having provider relations involved is really key from the OMS policy perspective as well, because the policy team does work really closely with provider relations, and that's kind of our finger on the pulse for what information is coming in. So I really welcome the idea of having the provider subcommittee, and as Michelle said, kind of separating that a little bit from the rate work, even though the rate work is so pervasive and important.
Well, that seems like a good transition to the rate section of the agenda. Want to pass it back over to Michelle and Amanda around any updates from MaineCare.
Amanda, I can start off with a couple high level comments, and then you can go through your more detailed updates. First, in the theme of lessons learned and implementation, I just want to acknowledge this has been a rough process for our implementation of the 1/1 rates, we are continuing to prioritize working through all the questions that have come up. We were able to finish updating the rates in our system, and we got out our first round of FAQs late last Friday, and are hoping / planning to follow that FAQ with an updated version as soon as possible. For us, I think that this is partly a cautionary tale about very aggressive timelines with very broad scopes, but that isn't sufficient. And so, as we have been building this Chapter 639 plane as we've been flying it, like we are having lots of conversations about processes and structures to put in place so that it gets smoother and smoother as we go on. So I just wanted to say that at the top. So more FAQs around the implementation side of things will be coming shortly. I will also note, I believe that we said this in one of our messages, and I want to reiterate the fact that we absolutely reviewed and took into consideration and had many conversations about the comments we received prior to rate finalization. Where we have gotten a little bit bogged down at the moment, and we are working closely with our vendor, is to make sure that all of those responses are documented. I had been hopeful, and we're still exploring. I was like, well, do we need to wait until we have all the comments for all the sections, or can we get out a section at a time so that we can start posting those responses? Like everything, it's a little bit more complicated than that because there are cross references and cross-section issues, but we're still seeing whether or not we can get some responses back sooner rather than later. But we continue to be hard at work at making sure that we've documented everything as we have committed to doing. With that, Mandy, do you want to start going down through your updates? And when we get to the COLA piece, if you're prepared to share that, that's fine. But if you'd rather kick that back over to me, then that's fine as well. If Mandy's, there you go.
Okay. All right, I'm probably gonna kick that back to you. I'm not sure if you heard me. Can you guys hear me okay? All right, so I just wanted to start off with a reminder, like Michelle said, to sign up for the listserv notices. And as far as the rate reform website where all of the studies, the work is posted, sometimes there's a little bit of a delay when a notice goes out as to when it's posted under the specific study. So I just wanted to remind you you can go to the bulletins page too, if you think you might have missed a notice. So sections 13, 17, 26, and 92, those have been implemented. Those rates have been implemented. Multiple notices have gone out, as well as 65 and 28 now. I believe we've sent out a notice February 2nd. And section 60, DME, those rates were implemented on 1/1, and we have posted the comments, and the notice went out yesterday. Ongoing studies, section 65 crisis resolution work, working with a vendor to finalize a work plan. There will be communications in the next month. Section 2, adult family care homes. Public stakeholder meeting to review draft rates was held on January 12th, and the comment deadline was January 31st. There's a January 17th message. With that, section 30, family planning. Kickoff meeting with stakeholders was held on January 26th. We went over our reform goals for this section. The presentation materials have been posted to the rate reform website under presented materials. Section 31, FQHC. The second informational session was held on Wednesday, February 1st, for additional discussions regarding quality assurance. There's a notice going out probably Friday with those presentation materials. Section 45 hospital, 3 categories. The acute section, we're still in the pre-work analysis phase with the vendor. inpatient psych, and substance use disorder. The comment deadline for draft rate presentations was Friday, February 3rd. Institution for Mental Disease. I believe we are requesting data. Section 67 nursing homes and 97C residential care facilities. We held a kickoff with providers February 1st. There was a January 20th invite notice. The presented materials notice will go out this Friday, but you can view those already underneath presented materials on the rate reform website. Section 107 psychiatric residential treatment facility. We're working with OCFS to finalize decisions on service models, and we're wrapping that work up. We do need to address a few outstanding issues. I believe the next step would be public presentation and comments. Date to be determined. Section 23, developmental behavioral clinics. The comment deadline for the public presentation of draft rates was December 15th. We're finalizing the draft rates, compiling comments and responses for posting. Section 2 to be determined, certified community behavioral health clinics, contracting is underway. And National Diabetes Prevention Program, which will be a new section. That one, we had public review and comment on draft rates yesterday. There was a December 29th invite notice. And on Friday, they presented materials and comment deadline reminder will go out in another notice. And then for upcoming studies for next year, just make sure to check our website, sign up for the listservs, and we're going to be sending out notices to kick those off. That's it.
Okay, and oops, sorry. I can, I know that Laura, there were questions that we just didn't have time to respond to prior to the last rate reform subcommittee meeting around COLA. And so I have some information to share there. I'm just going to share my screen if I can find what I was looking at. Hold on. Okay, so we've talked about this a few times. I think as everyone's aware, we implemented cost of living adjustments as well as adjustments related to Part Quadruple A, which requires that labor components of rates equal at least 125% of minimum wage. For everything that went into effect on 1/1/2022, we applied the 8.24% increase, which represents the increase to Maine's minimum wage. And we use that as the cost of living adjustment for rates that were updated for January 1. Similar to what we did last year, the services that are on a July 1 schedule for cost of living adjustments, those are really the non-Part Quadruple A sections of policy, will be getting that same 8.24% adjustment come July. And I'll scroll down for a second, just as a reminder to folks, Part Quadruple A, these are largely home and community-based service waivers as well as personal care related services. And those were the updates that went live in this past January, last month. Just noting that the rates that went live 1/1/23 based on rate studies were also required under Part Quadruple A. So those will be on this list moving forward. And then for the 7/1, the non-Part Quadruple A services include these sections of policy. And just as a reminder to folks, these are really the sections of policy that don't fall into Part Quadruple A and also don't have their own specific statutorily required COLA adjustments. So for example, nursing facilities and FQHCs, as a couple examples, have cost of living adjustments that are already required and in statute. And so they are not on this list. These are really the services that prior to Chapter 639, there was no regular practice or requirement for COLA adjustments for those services. There was also the question from the rate setting subcommittee about what assumptions were used for future COLAs. This is where we all wish that we had functioning crystal balls, because especially with the world lately, it has gotten harder and harder to accurately predict what a cost of living or what the inflation indices will be. So we looked at projections for CPIW. I think Moody's was a source. This included conversations across state government for what was appropriate here. And at the time the budget initiatives were being put forward, the assumption for January 2024 and the following July is a 2.84% adjustment. As we have well learned, we know that those projections, projections almost never end up being right on the nose. And I will just say that, how that COLA amount is dealt with once we get closer to implementation and know what actual COLA is a broader conversation that also includes the legislature. So this is TBD. Any questions or comments related to the COLA information? Or anything else that Mandy ran through?
I had a question. Michelle, that spreadsheet that you were just showing us, is that something that's been sent out, or was that just for this particular meeting?
We just finished it up this morning, so no, it is not. It has not been sent out at this point.
Mallory?
Hi, going back before the COLAs and the rates and the FAQs, the FAQs relating to assertive community treatment, Section 17, have actually raised more questions and concerns regarding the implementation of the changes, regarding outreach and whether that's counted or not counted towards attempts to reach. And there's concern that folks who are transient and homeless and hard to get hold of will be losing services or access to services as they become unbillable. And we'd like to try to set up a meeting or a discussion around the ACT, the sort of community treatment implementation of changes. And I can follow up with you offline, but I just wanted to give you a heads up on that.
Okay, thanks, Mallory. I think we'll absolutely want to include OBH and potentially OCFS in that discussion as well.
Not seeing any other questions. Should we move to Laura and the subcommittee?
Okay, we met last week, and our next meeting, we meet on a monthly basis, the Rate Systems Subcommittee of the MAC on typically the last Monday of the month. And I'll put the schedule through June in the chat for folks, along with the Zoom link. And I think at some point we'll try to get that online, because these are public meetings and we welcome certainly MAC members or any stakeholder into the meeting. Those are the last Monday of the month at 2 p.m. We were really happy to have Amanda in the meeting to share updates about the progress of rate determinations, many of which she, of course, shared here today as well. We also discussed the final steps and rollout of Section 13, 28, and 65 rates. And yes, it was a tight timeline. And I thank you, Michelle, for acknowledging some of the challenges with the rollout. We talked about, the stakeholder comments and, hope to see those very soon. Confusion about the timing and availability of the new rates and ability to bill. And we appreciate the work of the department to get those rates up and available. And I know they all are now. And the There was also a piece that we talked about, and this was a request for comments around putting those rates 1328 and 65 forward into, I believe it's into MaineCare benefits manual, but I need to go back and look. But it was a request for comments that came in December 30th with a turnaround for January 9th, really leaving people about 5 business days to do that. And so we just, have a recommendation for a bit more time when it comes time to, adopt new rates and get those final pieces in place for providers and stakeholders to be able to respond.
Laura,
yes.
Sorry, I want to make sure we're all talking about the same thing. And I was confused for a moment, but I think that what you're referring to is that there are federal noticing requirements for state plan amendments. And when we sent out the 1230 notice, in order to secure a 1/1 effective date, we have to send out a notice per federal regulation prior to the effective date, right? So on December 30th, we did our required state plan amendment noticing, and that all state plan amendment notices have an opportunity to submit comments. And I think that I'll defer to Jenny on this, but I think there's a standard time frame for those comments.
Okay.
To be honest with you, historically, I don't think that we've received many comments around the state plan amendment noticing, but that is separate from the comments process that goes with the APA process and MaineCare rulemaking.
That's good. And thank you for that clarification. It'd be good to know what the federal requirements are. And again, I understand the deadline and January 1 timeline that timeframe that you were trying to reach. It caught many of us by surprise. Some of us didn't see it because we were on vacation and felt like we missed an opportunity to comment. So if there's additional information about what is required and what traditionally the department does provide in terms of public comment for new rates, that would be helpful to have.
Sure, and I'll just note again that part of the intent of Chapter 639 is to have a robust enough stakeholder engagement process where there's a lot of back and forth. While comments are absolutely still important, and we need to have that opportunity both at the federal level and the state level, that it takes some of the pressure off those processes, since we are having our own separate process ahead of time to make sure that we're having meaningful engagement and dialogue.
Thank you.
Again, just to jump on, Laura, absolutely, we will be engaging in the regular MAPA rulemaking to adopt those rates, and it will be the regular notice and content process for them. And as Michelle said, the timing was just a challenge here. I think this was the only way that we could actually secure a 1/1 effective date, which we really needed to do. So,
thank you. I think there were just a couple more things that I would mention. We did talk about the COLA determination process, both what's required under Chapter 639, and know that the department's working on that with the TAP. And then Michelle, it's just thank you so much for taking the time to walk through what's in the FY24 and 25 proposed biennial budget. I think for a lot of folks looking at that, you see a large dollar amount, but knowing what that means as an individual agency about your own budgeting, even just looking at knowing, well, there may be something that's 2.84%, knowing that it might change is helpful at this juncture. So thanks for pulling that together. And then we did flag the what it looks like for the HCT, an alternative payment model soon to come, and knowing that there's a rate, but looking at guidance. So I appreciate that is on the agenda as well today. Thank you.
yes, thank you, Laura, and I can speak to that question. And so the intent is for the pay for performance measures, those will not be in place until we have engaged in stakeholder consultation and rulemaking. So the rate itself is available for billing, and there will not be a pay for performance component to it until after we complete the rulemaking process.
Okay. Do you imagine that process sometime in the next 6 months?
Certainly hope so.
I think, go ahead.
Sorry, I'll say that in addition to the APA process, I think our delivery system reform unit also has plans for additional engagement on the topic. So, there will be more outreach prior to the proposal process.
Okay, thank you. And I think I'll just share one of the requests that came from committee members who were talking about this, and that's always the concern about not having the guidance right now. It's great that folks can go ahead and bill, and that it's great to note that there's stakeholder engagement coming on it. But the concern was, what do we do with PIU a few years from now when they come back and there is guidance, but we don't necessarily have the documentation or the things in place? And could there be something written from the department regarding that for folks who have that concern? Thank you.
And Laura, if you take a look at the FAQs that we released on Friday, there is a question and an answer to that regard, where we acknowledge that yes, we will practice enforcement discretion during this time when there's not sufficient clarity for everyone to be able to make sure that they are crossing all their T's and dotting their I's.
Thanks very much.
Mark?
Yeah, just clarification on the HCT for January moving forward until the performance measures are made public and implemented. So we just continue to bill for the clients that we're working with, but we're not going to be held to, for this example, the 3 contacts per week per family. So for HCT, that's the requirement. And I just want to make sure I'm explaining this correctly to my staff, that continue to do what you're doing, essentially. No changes in the number of contacts, but we'll bill at that new rate starting January 1. Is that correct?
So the department is still working on additional guidance. So as Michelle mentioned, we're working on some additional FAQs. HCT is one of the areas where we have not yet answered all the questions that we're intending to answer. So I would say stay tuned for further guidance on that. What I was referencing was specific pay for performance measures will not be in place until there has been the DSRU process that Michelle described and the rulemaking process. But we do look for further guidance on HCT because we are planning on issuing some.
Okay, so for January bill, as we have before, but with the new rate, but we don't need to go and track, okay, we met the 3 contacts per week requirement for this family, therefore we can bill for it and feel confident in doing that. We can just, if we've worked with, I guess the standard is, if we've worked with a family that week, we'll submit a bill and get paid the weekly rate. Because it's, yeah, I'll stop with that first.
So Mark, as stated, we'll be getting out additional clarity this week. I would say in the interim, as under current policy, continue to document what you're expected to per that policy, and proceed with billing as you need to. I know that that's a little bit loosey-goosey, but don't stop doing anything that you've been doing previously in terms of documentation and service requirements. And we are not going to be, if we put forward additional guidance that is not precisely what you've been doing, we're not going to be coming after providers because they have failed to meet the guidance that we don't have out there yet, if that makes sense.
That does make sense. My only concern is that there has been guidance around the 3 contacts on average per week for families. I know we're not doing that with all of our families. There's no way we could turn on a dime like that. Our billing system isn't set up that way, and it would probably take at least 6 to 8 weeks to do so. So we'll continue to document, obviously, in the way that we are, but there are plenty of families we probably have 2 contacts with, and we're providing that service, and under the 3 contact rule, we'll get $0. So we just need to know immediately which standard we're going to be held to.
Okay, and I can say that we'll prioritize this week getting an answer to that specific question. It's not the only thing that we're looking at for this week, but I get that that's a key question for you.
Great, thank you.
Okay, let's move on to rulemaking. And so Jenny, back to you.
Great. Thank you, Kathy. I actually don't have a lot. I'm happy to answer questions. I think as we have been discussing throughout the course of this meeting, a lot of things have happened recently that will really drive the priority of our rulemaking. And so one of those is knowing for sure when the public health emergency is ending. So one focus that we will have is on finalizing the COVID emergency rule that kind of memorializes the COVID flexibilities. We also, I know there was a question about the HCBS services, and again, as I think was discussed, the Appendix K flexibilities extend for 6 months after the end of the public health emergency. So we do have a little bit more time on those, yet at the same time, there is a lot that we are hoping just to have a smooth transition in terms of retaining some of the flexibilities that have been in place during COVID and actually adopting them formally through rules and through waiver amendments and updates. And so I think it may well make sense to have there be a discussion of that at some future MAC meeting. I don't know exactly what the timing will be, but I think those are good questions and they're certainly an area of focus for us. Also, again, we are focusing on rulemaking related to the rate system reform, including the COLA rule and implementation of rates from some of the rate studies. So all of that is it's on our plate, and we now know what our timeframes are for focusing on it. So that is helpful. So that's really all I have for today, unless there are specific questions.
Any questions? Laura?
Any update on section 106?
It's a high priority for us, and I think stay tuned for more. I think there was some overlap with that and the behavioral health rate implementation. So I think that set us back in our timing a little bit, but it's a really high priority.
Thank you.
Okay, thanks, Jenny. Communications updates, Shannon.
Hello, everyone. We have had a lot going on, and as I guess the biggest update that I can give is regarding member engagement. So to assist and to expand the member engagement work that we're currently doing, we've hired a member engagement manager. So this individual will start later this month. And the person in the position will have regular interaction with internal and external stakeholders, such as community-based organizations, advocacy organizations, the public, our vendor partners, teams within OMS and the department as well. And we're hoping that they'll develop some avenues to engage members so that they can inform changes to our program. And that's really just a kind of a teaser. And that's really the biggest thing that I have to give as far as an update.
I'll give.
Molly, if you're trying to speak, the conference room is muted right now, so we can't hear you.
Whoops. Okay. Can you hear me now? Thank you. I'll just give a communications update as well, which is that Shannon is formally in the position right now of acting director of strategic planning and communications. So that's the role that Eric had previously been in that vacated. We are actively recruiting, and Shannon didn't introduce herself with that title earlier in the meeting, so I wanted to give her that shout out. So so thanks to Shannon for taking on that role while we are recruiting for the permanent position.
Thank you. Any questions? Okay. So just a reminder that our next meeting is March 7th at 10 a.m. And I do not think anything was flagged as a specific agenda item for the next meeting. Please let me know if I'm wrong. But I'll also do a request for agenda items, and you can send agenda items along anytime, as usual. Any last questions or thoughts? Okay, thank you all. Have a great rest of your day.
Thanks, everybody.
Thanks, everybody.